Hello, my name is John Kitchens, and I'm a physician with Retina Associates of Kentucky. I'd like to spend just a few minutes talking to you about age-related macular degeneration. Age-related macular degeneration is the leading cause of vision loss in patients over the age of 65. Age-related macular degeneration, by its definition, is a degenerative process. It's a degenerative process of the retina, which is the light-sensitive nerve tissue that lines the back of the eye. The region of the retina responsible for the center vision, and that's at the very back of the eye, is referred to as the macula. The macula is very important because it's responsible for your central vision. As we get older, aging changes can occur throughout our body. In the macular area, these aging changes are called drusen, and they are little yellow deposits that develop in the back of the eye underneath the retina, and most of the time these drusen are asymptomatic. The problem comes when your body tries to reabsorb or get rid of these drusen by growing new blood vessels underneath the retina. This is called wet macular degeneration. These aberrant, abnormal blood vessels grow under the retina and they bleed and leak and cause loss of vision. Typical symptoms of wet macular degeneration can include distortion, decreased vision, and missing spots in the central vision. If you notice any of these symptoms, you want to contact your doctor immediately for a referral and an examination. Oftentimes, if you're diagnosed with wet macular degeneration, your doctor may refer you to a retina specialist. A retina specialist is an ophthalmologist who specializes in diseases of the back of the eye. When you come to see us, we will do several different things to determine the type of macular degeneration you have, as well as the best treatment options for you. The first thing that we'll do is take a careful history. Next, we'll check a visual acuity. A visual acuity is very important as a starting point prior to therapy to know exactly how you respond. It's important to bring your glasses when you come to see us so that we can get the best visual acuity possible. Along the way, we'll do the basics of an eye examination, including checking your intraocular pressure and examining the front of your eye, while we also look for cataracts and other ocular problems. However, it's not until your eye is dilated, and you will need to be dilated to diagnose macular degeneration, that we will really see the classic findings. Oftentimes we'll utilize a variety of different tests to help us make this diagnosis. One common test is an OCT. This stands for optical coherence tomography. And an OCT is a digital scan, a laser scan, through the retina, and it allows us to look at the retina in cross-section. We may also obtain other imaging, such as OCT angiography, fluorescein angiography, and fundus autofluorescence, to better allow us to diagnose and follow or treat your macular degeneration. After an exam and appropriate testing, we'll then discuss a variety of treatment options. Treatment options often center around injections in the eye of anti-VEGF therapy. Typically, we'll put a lid clamp inside the eyelids to hold them open, and then we'll have you look at a target and we'll inject through the sclera, the white part of the eye. You shouldn't see the needle coming directly at your eye. As with any injection in any part of the body, there's a risk of infection, which is about 1 in 3,000 to 1 in 5,000. There's also about a 5% chance of a red eye or an irritated eye. Both a red eye and an irritated eye will improve over about a week or so. If several days after your injection you start to see increasing floaters or decreasing vision, you'll want to give us a call right away, even if it's on the weekend. This could represent a rare but potentially devastating infection. Now, I know no one wants to get a shot in their eye, and everyone's always worried, will it hurt? And I will tell you that it's very uncommon for these injections to be incredibly uncomfortable. There are 3 main medications that we use to treat age-related macular degeneration. Your doctor will have a discussion with you about which medication is most appropriate, which medication your insurance will cover, and which medication is right for you. It's not uncommon for a doctor to give several injections of one type of medicine and then switch to another if they don't see a complete anatomical or visual acuity response. In other cases, your insurance will actually tell us what medicine we can use. Regardless, these injections are the standard of care, and they are very safe and very effective. Clinical studies which led to the approval of some of these medications showed that up to 40% of patients will achieve 20/40 or better visual acuity at both 1 and 2 years. The chances of a patient gaining 3 or more lines of vision is somewhere around 30 to 40%. One question patients often have is, how many shots will I need? When you first come in, it's impossible to tell how many injections you're going to need. In general, we'll use several criteria to determine whether or not you need additional treatments with each follow-up visit. Oftentimes, I consider 4 main variables. The first, how do you feel like you're doing? Do you feel like your vision's getting worse? Are you having worsening distortion or decreased vision? Second, what's your visual acuity? Has it improved compared to last time, or is it worse? Third, your examination. Do we see new hemorrhage in the back of your eye? If so, we're going to want to treat that. And fourth, what does your OCT scan show us? So in essence, really, the way your eyes respond to the injections will tell us how many injections you need. So how do we determine how to treat patients? Well, a lot of doctors do things differently. If we're treating according to the Phase 3 FDA studies, which led to approval of 2 of the 3 medicines, we will treat you every month or every other month. Most doctors don't treat based on those clinical trials. Some doctors will choose to utilize what's called a treat and extend model. And what this involves is giving a series of injections, typically 3 to 5 initially, every month to get the retina completely dry. Then when we see that the retina has reached its maximal dryness, that there's no more leakage to be treated, we'll often spread out the interval between injections. So for instance, you may come in initially for monthly injections for the first 3 months. 1 month after your last injection, we'll check the scan, do an examination, look at your eyes, and look at your visual acuity. If the scan is completely dry, I'll likely give you an injection that day, and then we'll see you back, instead of at a month, we'll see you back at 6 weeks. We'll perform the OCT scan again, and if everything looks completely dry and the visual acuity is stable, and you're asymptomatic with regards to any changes, then we'll go ahead and give you another injection, and we'll see you back at 8 weeks. Let's say now that you come back at 8 weeks and we see the OCT shows new leakage. Well, then we know that the medication is not lasting 8 weeks and that your eye is starting to leak prior to that, which is not uncommon. At that point, we will then back off the dosing to intervals of every 5 to 6 weeks for, say, the next 3 to 4 visits. That allows us to stay one step ahead of the blood vessels. We really don't want to see those blood vessels coming back and leaking repetitively. Another common question that patients have is, what's the chance that I'll get this in my fellow eye? We've actually been involved in a variety of studies, including the age-related eye disease study and the age-related eye disease study number 2. What those studies showed when it comes to the involvement of the fellow eye is that patients who have wet macular degeneration in one eye are at an increased risk of wet macular degeneration in their other eye. But some of the clinical findings we see can actually predict an increased rate of wet macular degeneration. So in other words, if the good eye, or the eye with the dry age-related macular degeneration, has large, soft accumulation of those deposits, drusen, and pigmentary changes, and the affected eye has wet macular degeneration, the good eye, or the dry AMD eye, now has up to a 50% chance of developing wet macular degeneration over 5 years. Can we do anything about that? Absolutely. The ARADS and ARADS2 study showed that there could be a reduction in the occurrence of wet macular degeneration in the fellow eye by taking vitamins. Your doctor will look at your eyes and will tell you if vitamins will benefit you. What about your children? Well, we know that genetics plays a key role in the development of age-related macular degeneration, as does smoking and environmental influences such as diet. Up to 50% of cases of age-related macular degeneration have a genetic component. But that doesn't mean that your children are going to get age-related macular degeneration. In fact, those ARADS studies that we were a part of showed that there was no benefit to the ARADS vitamins if you did not have macular degeneration, or if you only had mild, dry, age-related macular degeneration. So it's not essential that your children start taking these vitamins. Many patients worry about their good eye developing wet age-related macular degeneration while they're undergoing injections. The first thing to realize is that once you've been through the onset of wet age-related macular degeneration in one eye, you're typically very keen to the symptoms of wet age-related macular degeneration in your fellow eye. In addition, we'll ask you to check an amsler grid as well as monitor your vision in that eye several times a week. If you notice any changes, please give us a call. And as you return for your follow-up visits and treatments, we will obtain OCT imaging and examine your fellow eye on a regular interval. This will help us pick up early signs of wet macular degeneration. Many patients are concerned that they're going to go blind with age-related macular degeneration. And although complete blindness can occur, it's very, very rare. Typically, wet age-related macular degeneration, if left untreated, will rob the patient of their central vision. But the peripheral vision, the vision that we use to see, to get around, to navigate, and things such as that, will remain intact. One other thing to remember is that even though you have wet age-related macular degeneration, your dry age-related macular degeneration didn't go away. Unfortunately, it can still progress. And these treatments for wet macular degeneration really don't do anything to help with that. There is one potentially devastating form of dry macular degeneration that can cause vision loss, and at this time is still yet untreatable. It's called geographic atrophy, and we'll talk about it in another segment. Once again, I want to thank you for watching and for learning about wet age-related macular degeneration. Hopefully some of your questions have been answered, some of your fears have been allayed. We are so fortunate to be able to have these revolutionary treatments to be able to help you. And we want to thank you for choosing Retina Associates of Kentucky.